Welcome everybody to our TIF Talk special edition. I'm very excited today because we have a special story when the doctor becomes the patient. So we are here today with Dr. Yasser Salem from OC Reflux. He's a general surgeon. Thank you for being here.
You're welcome.
And we're also here with Dr. J. Robert Evans, gastroenterologist from San Bernardino, California, by the way. We're in California. And he's at St. Bernardine Medical Center, correct? Awesome. Well, thank you both for being here today. We're very excited to talk about Dr. Evans' story and Dr. Salem, who actually did Dr. Evans' TIF procedure. And Dr. Evans, you also do the TIF procedure.
Correct.
Right. So tell us a little bit about it. You had your TIF procedure from Dr. Salem.
Yes.
About 5 years ago?
5 years ago, yes.
Okay.
And it was a good thing I did TIFs, or I probably would not have known that I needed one.
There you
And
go.
I have what's called atypical symptoms of GERD.
Okay.
And those include hoarseness, throat clearing,
Right.
chronic cough, and asthma. I've got all of those.
All of it.
All of it. And when it came time for me to do something about it, I couldn't do a TIF on myself.
That would have been interesting.
So the insurance wouldn't let it go through.
Okay.
So I had to find someone else to do it.
Right, of course.
That's when I met Dr. Evans, and it was a pleasure to meet Dr. Evans at the time.
Excellent.
Because I had been doing this procedure for several years.
Right.
And when he came along, he said, I believe in this procedure so much. It was nice because at that time, not everybody was doing this procedure. Okay. So it was nice that we had common ground.
Right.
We both have the same understanding and we believe in it. And now today, you can see where the procedure is. It's gone crazy. It's a lot of people are doing it now.
Right.
And it's just about everywhere you can have this procedure done.
Right.
So it was a great meeting. We met, and here we are today. It's 5 years out. We're sitting here together, so he's very happy with the outcome and he's satisfied. And so I'm sitting next to my patient.
How satisfied am I? I'm satisfied enough that when my wife lost her voice
Yes.
in July,
Right.
well, I knew exactly what was going on.
Okay.
So I directed the workup, and then I got my wife to Dr. Salem because I missed her sweet voice so much.
That's so sweet.
Yes.
So she also had the TIF
She has
procedure,
also had a TIF.
But it's been, what, 6 months?
Been about 6 months.
Okay.
And, she's speaking again.
Oh, well, that's good.
And it is good. It's amazing. You may dream about not hearing your spouse's voice, but when she actually loses her voice, I couldn't wait to get
The voice
her
back.
voice back.
Yes.
That's great. So it's interesting because you are a GI and you are seeing these patients that come to your office, and you're probably seeing them too, Dr. Salem,
Yes.
complaining of typical symptoms of GERD and also, as you mentioned, atypical symptoms of GERD. So let's talk about a little bit more about GERD and talk about more of the scientific part of GERD. So as a GI, how do you explain to your patients what GERD is and how do you talk through that with them?
If they have symptoms of heartburn, that's a common one, chest pain, they may even be having trouble swallowing as part of that, then that initiates an evaluation to try to find out what the problem is. And all the time I'm thinking, first of all, is this what is really going on?
Right.
My initial impression of GERD. And second, what is the best way of fixing GERD for this patient?
Sure.
And sometimes the best way is put them on pills.
Right.
But what happens if they're young?
Right.
And I have to say, for the next 60 to 70 years, you're going to be taking pills 1 or 2 times a day. And that doesn't even get into the potential side effects of those pills. Just the fact of taking pills. I'm not sure that's the best treatment for everyone. And right now, pretty well everyone is getting that treatment who has constant GERD, and that's about 20% of the population.
Right, right. It's prevalent. So, Dr. Salem, do you also have that same conversation? How do you see it in your practice?
Your patients come to you directly, or do they get referred to you?
I'm glad we're having this discussion, because next to me I have gastroenterologists. So typically patients, when they have heartburn per se, they get referred to a gastroenterologist.
Right.
So why is a surgeon sitting here? How am I able to work up these patients? Apparently, a lot of patients, it's a fact, a lot of patients have heartburn. Right. A lot of people. So as a surgeon, as a doctor, any specialty you are, you're gonna run into these patients, whether in the hospital, in the office. Sometimes they're coming for something else, and then they say, I noticed that you specialize in heartburn, and they could be here they have their gallbladder removed, or sometimes they have breast cancer, or some other medical condition that is not heartburn. Right. But it turns out that most of my patients, a lot of my patients, have significant, not regular heartburn, they have significant heartburn. Right. So I am now in the position to not only be a surgeon, but be a medical doctor and do what Dr. Evans is doing. And I start by getting the history. And the nice thing about what I do with heartburn is that I find sometimes patients that don't really have heartburn, but they're on medications anyway. And that's it. That I say, probably 1 out of every 5 patients I see in my practice are on heartburn medications, but don't have heartburn. Well,
the studies say 50% of those who are on pills for heartburn don't need them.
I said 1 out of 5. I think it's probably more than 1 out of 5. And so the scenario is, I have a patient who I did some procedure on that is not related to heartburn, and they happen to be on heartburn medications. So obviously I'm gonna ask, how did you get placed on this medication? Right. And sadly, I wanna make sure everybody understands, some of these patients have been on it for 10 years. And I say, have you ever had workup done? And the answer, unfortunately, is no. So they're on these medications for 10 years and no workup.
Now, workup means beyond symptoms alone.
Beyond symptoms. And 50% of those ones I'm talking about that had no workup, the physician started the medication, usually a primary care physician, but 50%, the patient started the medication.
I was just going to ask.
And I just want to, I want to make sure that everybody, be aware of this pitfall, that your neighbor, your wife, your significant other, not wife, husband, wife, family member is going to say, I'm taking this heartburn medicine. Your symptoms sound like heartburn. Why don't you just go get it? Because it's available over the counter. Right. And I just want to make sure these drugs are available, but they have significant side effects. And that's something to be careful of. I mean, you can take it for a short period of time, but beyond, I think, 12 weeks is recommended.
Right.
And that's 12 weeks, it says on the medications, that is if prescribed by a physician, right. Not self-prescribed. But patients will self-prescribe these very strong medications and stay on them for 10 years. So I start by getting a good history. Then I find out when they started on the medications. So the first thing that I'd like to do, is prove to the patient and to myself that they indeed have significant heartburn that we call. Right. So that's where the workup starts. And then of course talk about the symptoms, which Dr. Evans has atypical. Right. When he came to me as a patient, his symptoms were atypical, which is voice. We call that, the lingo we call is LPR, which stands for laryngopharyngeal reflux. Right. So they're really advanced. They're beyond the regular heartburn that people get with the chest pain and all these things. The symptoms is way up in the
And I never had heartburn.
You never had heartburn?
You never had the feeling of heartburn?
I maybe 3 times in my life have I ever had heartburn. That wasn't my problem. The interesting thing is LPR is actually harder to treat than the heartburn up into the chest, the burning in the chest.
Because it's significant heartburn, because that means, in theory, anatomically, I'm a surgeon, so I always think about anatomy.
No,
so
I love it. This is great. This is awesome to have a GI and a surgeon.
So I always think in conceptually anatomy, what's happening here. Your stomach, for everyone that, for those of you, I'm sure those watching are very familiar, but if you're not, your stomach is here, and the acid is here. And I want you to know, acid is good. Acid is very good. We all have these medicines that are anti-acid.
Right.
as if acid is the devil. But please clarify, acid by itself is not bad. It's good, it's needed, it's natural, it's something that we all have, but it's got to stay down here. You need it for eating, you need it for digestion, as long as it stays here. But can you imagine patients like Dr. Evans who had voice changes? This acid is not refluxing to here, it's up into the throat, to the throat, and to the vocal cords, to the point that the patient will lose her voice in speaking. Like if I'm talking right now and I have heartburn, I will lose my voice, and then I have to excuse myself, and then I may or may not come back, and depending.
And I was to the point of having had voice problems for a year,
right,
and having been only able to whisper.
Wow.
To my patients, to my family, for about 4 or 5 months when I saw you. And I'll tell you, if you don't have a voice, you are on the sidelines of life. You know, you're just sidelines.
Yeah.
After a while, people forget you're there, and
So
it's a horrible experience.
Yes.
So after you had the TIF procedure, when did you notice a difference with your voice?
No, that's a good question. This is amazing. I think I've told you this. Mm-hmm. The morning after the TIF, I could feel my vocal cords vibrating like I hadn't felt them vibrate in a year.
I believe that, yes.
But it took 6 months before I could sing a hymn at church, and it probably took a year, and I still have some trouble. I've got to be careful with my voice. In other words, I think there's permanent damage that occurred from allowing the heartburn, or not the heartburn, the acid to scar my vocal cords probably for years.
Because you told me you had to see a vocal specialist, right?
I did, and she evaluated it. There was bowing of the vocal cords.
Okay.
One of the vocal cords was a little paralyzed. I don't know that has anything, either of those has anything to do with acid reflux.
Okay.
I'm suspicious the bowing does. There's no study that
Right.
says that. But she injected substance into my neck to try to push the vocal cords together so I could speak better. She sent me to speech therapy, which is a great place. My daughter's a speech therapist,
That's great.
but she doesn't specialize in rehabbing
Sure.
laryngeal problems or vocal cord problems.
Okay.
I worked with them for about 6 weeks. Finally, I said, you know, I'm better than I was, but I'm not as good as I need to be. I'm still having a horrible time talking. I then directed my colleagues
Right.
to perform endoscopy, look down in my throat. That's what I do. The throat's one of the places I look. But down in the throat, see if there's any damage.
Yeah.
And he's an excellent gastroenterologist. He couldn't find a hiatal hernia there or acid burns. Mind you, I was on like 3 times the normal dose of
PPIs.
proton pump inhibitors at that point. And then I had a test done to measure the acid. This is kind of what you were alluding to.
Exactly.
You've got to do something to really know what's going on. And I had acid that was a little above normal, but I thought, this has to be the cause of my problem. Right. And a week later, I was in your office.
Yeah, once he diagnosed it, and that's what I'm talking about, the workup, because the workup is history. History gives me, when patients come in for a new consultation, I spend close to half an hour, 45 minutes getting a very detailed history. First encounter is very detailed. That's a big part of it, but that needs to be supported and confirmed by testing. And that testing involves endoscopy. Upper endoscopy is very sensitive in the right hands.
Right, that's what I was going to say.
In an experienced operator, gastroenterologist or surgeon, or somebody who, make sure it's somebody who specializes in heartburn because they know what they're looking for.
Right.
Now, when you looked in me, after I was put under general anesthesia, everything relaxes. Do you remember if I had a hiatal hernia?
Definitely.
Yeah, I did.
Definitely had a hiatal hernia. And so this is what Dr. Evans is talking about, is most endoscopy is done under sedation.
Right.
Now, sedation doesn't use any muscle relaxant. Right. So just remember that the diaphragm has a muscle. So if that muscle is not relaxed, it might be tight. That's just because there's no muscle relaxant. So you cannot properly assess the size of that hernia.
Right.
Sometimes you get lucky and you can, but I can tell you, even endoscopy in the best hands underestimates the size of the hernia. I think we all agree that everybody with heartburn has a hiatal hernia. The question is, what is the size? And that's the big question.
Yeah, thank you for bringing that up, Dr. Salem. There's always a question from our Facebook, the communities, and they always talk about, what is a hiatal hernia? My doctor said I have a hernia. Can you explain the difference, what the hernia is and what the actual, can you go into the scientific part?
I wish we had a diagram.
I wish I had a diagram, but I'm going to try to be as simple as possible to explain to
How
you.
you would to your patient.
So, you know, when I sit with my patients, a lot of them, everybody's heard about a hiatal hernia. So when they come into the office, the hiatal hernia is a big thing in their eye. Oh my God, doctor, I have a hiatal hernia. So my first approach is to alleviate the tension and make sure that, listen, it's a hernia. So let's talk about what a hernia is. A hernia, for those of you that don't know, is a defect. It is a wide opening, okay? And what we're referring to is a diaphragm. The diaphragm has a defect. That's what the problem is. And the diaphragm, once again, is a muscle. So when that muscle, over time, now some people are born with a hiatal hernia. A lot of those are, if you're born premature, if you know someone that's born premature, a lot of times they have a hiatal hernia. So that's one of the risk factors. So you could be born with a hiatal hernia from prematurity or congenital. But the most common hiatal hernia is acquired over time because it's a muscle and it weakens over time and it gets stretched.
Every breath you take is putting stress on that muscle.
On the diaphragm, it gets looser. So what happens then is the stomach, remember the acid is good in the abdomen. The stomach, it starts to migrate into the chest because now you have a hole to go through. And that's what a hiatal hernia is, okay? It's a defect in the diaphragm and it's a mechanical defect. So no medication that we are aware of or has ever been produced will fix a hernia. A hernia is a mechanical problem that needs to be fixed. It needs to be tightened mechanically. Now,
so it's when the stomach, which is supposed to be all below the diaphragm, when some of it pops up into the chest cavity, that's a hiatal hernia.
So now you no longer have the acid in the abdomen, in the stomach. Now the acid is in the chest. That's when the problem starts. If it's not fixed, then the acid migrates further to the mid-chest, upper chest, into the throat, into the mouth, into the oral cavities, and then all the symptoms that we are talking about start happening. So a hiatal hernia is nothing more than a defect in the diaphragm. Now, I want to clarify one thing about the size, because that is a question that me and my patients talk about all the time.
Right, yeah, please.
What size is my hernia, doctor? There is no test that will measure the size of the hernia 100%. There's no test out there. Now, a lot of studies will hint. Now, I can tell you, if you come into my office with a CAT scan showing a hiatal hernia, it's a big hernia. For a CAT scan, a CT scan, to see the hiatal hernia, that's a giant hiatal hernia. Every single patient that's come in with a CD showing a hiatal hernia, it's 5 centimeters plus. Now, the normal opening in the diaphragm is about 1.5 centimeters. Okay? So when you get up to 2, it's not that much, it's 0.5 centimeter bigger, it's a hiatal hernia. But the patients, I will say the average size that I see is about 3 to 3.5 size hiatal hernia. But we see upwards of 10 centimeter hernias. Giant, we call those giant, where the entire stomach and other organs are in the chest, like the spleen and the colon is in the chest. But these can be large hernias.
My wife had I think a 2 centimeter opening in the diaphragm and a 2 centimeter height of a hiatal hernia. Those two are usually very tightly correlated. But at 2 centimeters, when we measured her acid, she had the worst acid reflux I have ever seen anywhere. Wow. When you look at the actual numbers. Really? Hers was 10 times as bad as mine was.
Wow. Okay.
But her hernia was smaller than mine.
And I will tell you, on Dr. Evans' wife, since we talk about this, had she not been in the situation with Dr. Evans involved, I'm involved,
Right.
she may have not had the acid test. Because the hiatal hernia, it's small, it would have been read as small hiatal hernia.
Right.
And
If
she
at all.
may,
If
at
at
all.
all.
And basically, she could have been having basically a normal endoscopy. So she would not have gotten a treatment. And she would have,
Yeah, let's talk about that. Let's talk about the different tests that you guys normally do when you're trying to determine what type of treatment option you're going to give for someone that's suffering from GERD. So,
Okay,
Yeah.
I'll field that one.
Yeah.
Because I'm the one that's usually doing that testing.
right, yeah,
If they come in with, I'm a gastroenterologist.
right,
That means they're going to get scoped. It's almost, they get sent to me by their primary who's expecting them to get scoped. They are expecting to be scoped, and I learned so much information from the scope.
right,
They're going to get scoped.
Okay.
Rare exceptions, but almost always.
sure,
So I put the camera down. What am I looking for?
Right.
I'm looking for actual acid burns in the throat. However, 50% of people that have acid coming up don't have the acid burns you can see in the throat. So, that if they're there, that's great. You know what's going on.
Right.
If it isn't, you don't really know whether there's acid or not.
okay,
I take biopsies and look for microscopic evidence of acid, and that helps as well. And then I spend a lot of time looking at where the throat, the esophagus, comes together with the stomach, because that's where the hiatal hernia is. I spend a lot of time there. What is a lot of time? It means I'm going to take 7 minutes to do the case instead of the 3 minutes that is frequently done.
right,
It's not really that much time, but
Right.
a lot more time than usual, because I'm going to take time looking in retroflex, see if I inflate the stomach, if the hiatus opens up, and if a hernia pops up. And sometimes it actually takes a while.
for it to show.
I think there's many gastroenterologists who would debate your statement that if you have reflux, you have a hiatal hernia. I don't think I'm one of them. It's almost always there in a patient that truly has reflux. So you have, again, an anatomical defect.
Plus,
Something has to be done.
right,
Not everyone with a hiatal hernia has reflux problems.
yeah.
Yeah, some of them are just there, and if they're not bothering the patient, you don't do anything.
sure. So now, Dr. Salem, do you do your own endoscopies as well?
I do, I
Okay.
do.
So as a general surgeon, you can also do the endoscopy
Absolutely,
test as well?
and you have to check if you're gonna go see a general surgeon for this. Just
Right.
make sure they do endoscopy.
Right.
And you almost have to make sure they do TIFs.
Yes,
Because if they aren't doing TIFs, they don't know how to carefully evaluate that junction between the esophagus and the stomach.
right. Basically, the surgical treatment of severe or significant heartburn has always been surgically is a laparoscopic Nissen or a Nissen fundoplication.
Right.
Some of you are aware of that term. That procedure has been around for a long time.
Right.
And the folks that are listening, I don't want you to think that it's a lot different from a TIF procedure. It is what I look at it as an advance of the Nissen procedure, okay? Because the TIF procedure, the TIF procedure follows the same basic surgical principles as the Nissen. It's basically based on the same foundation. They could be related, but it's an advanced version. So it's not a different procedure, because a lot of patients will say, why should I get a Nissen and why should I get a TIF procedures? Keep in mind, they are very, very much related. Same principles. You're going to fix the hernia and you're going to create a valve in the sphincter, and then you're going to tighten up the GE junction to prevent acid reflux. So it's the same thing, but it's an advanced procedure.
Right. Which can be done by a GI and also by a general
It
surgeon.
depends. I'm limited in that if it's a big hiatal hernia, I'm calling for my surgical colleagues
fix
to help with the procedure.
Right, right. So do you want to go into a little description about the TIF procedure and how it works?
Absolutely, absolutely. So TIF procedure, TIF, it stands for trans-oral incisionless fundoplication. So it's a very exciting, it's a very nice procedure because obviously it's in the name, it's incisionless, and it was made that way, it's created to be an incisionless option for patients. And basically, it is passed under anesthesia, down through the mouth into the esophagus, and under vision. Keep in mind, the Nissen procedure that is being done today, and has been done for the past 70 years, is not under vision. It is a blind procedure, right? Because you're working from the outside.
Right.
Where the exciting part about TIF procedure, it is the entire time, it is under direct vision.
Now, when you say blind, the surgeon's looking with his laparoscope.
Let me explain what blind is. I wish I had a diagram.
I know we should have asked you to bring a diagram.
So basically, you're working from
Hand me
the
that piece of paper.
outside of the stomach, and you're creating a valve. The valve is not meant to be outside; it's meant to be inside the lumen.
Right.
But you're creating it with the vision that I'm doing a valve in this area, but you don't know really what that valve looks like.
Good point.
So that is, to me, an advantage of the TI procedure, because the entire time you're watching the gastroesophageal junction when we do a TI procedure. So when it was invented, years ago now, it was invented to accommodate and to treat a hernia that is 2 centimeters or less. Now, we just said that majority of patients are 3 centimeters to 3.5 centimeters. So
Those are ones you get sent.
I get even bigger.
The little ones, a majority of them I see are about 2 centimeters. I see a whole lot of those, but they don't necessarily need to get a TIF or anything else.
So those, if you're that patient, typically those are younger patients and they just started getting reflux, they have a small hernia, those are excellent to have what's called a TIF procedure. It's a very, let me talk about that one, it's a very quick procedure. It is done primarily outpatient, maybe an overnight stay, and the recovery from that procedure is an endoscopy. There's minimal, mild pain postoperative. This is if you have the TIF procedure by itself. Now, so you're limiting this procedure to only patients who have a 2 centimeter hernia or less, but you're gonna exclude a lot of people. What about everyone else? The patients that Dr. Evans said that I see, I get the big, large, humongous hernia.
You get the hard
What about those patients? Well, no problem. All we need to do is convert that large hernia into a 2 centimeter defect or less. So what we do, we call it a hybrid, kind of like a hybrid car.
Right.
So it's half electric and half, I guess the electric part will be the TIF and then the gas will be the surgery, because gas is old.
I've never heard of that analogy, but that's
So I just thought of that, by the way. See, that's why being live is cool, because you can just off the cuff.
this is awesome.
So you just do a hybrid. So the hybrid is, we thought, wait a minute, why limit this beautiful procedure who's got great outcomes to just patients who've got a 2 centimeter hernia? Let's see if we can include the folks who've got a 5 centimeter, because it's a good procedure. Right. So easy. Instead of Dr. Evans doing this by himself, right, we team up.
Yep.
So I will come in and fix the hernia. The big hiatal hernia, that is a big bad word that sounds giant, I can tell you the average time it takes to repair it properly is about 30 minutes.
Wow.
30 minutes it takes to repair the hiatal hernia. The average time. Depending if it's a recurrent or a redo, it could be upward an hour, hour and a half, how complicated. But the average time is 30, maybe 45 minutes to do a hiatal hernia repair. Then the procedure is turned over to Dr. Evans, who will then do the TIF, transoral fundoplication, and that combination has improved the results several folds.
When you're talking about results, what is the complication rate of the old-fashioned fundoplication?
That's a very good point.
The old-fashioned fundoplication, I am both, unfortunately and fortunately, I've done it. So because I have done it, I've been treating heartburn for over 20 years. And in the beginning, when I started my practice, the only procedure available to patients was the Nissen. I was trained, I came from a program where it was heavy laparoscopic Nissen fundoplication. It was a main training surgery that we did. We all came out trained to do that. So I did this procedure. Now, in an academic center doing this procedure, a lot of times you don't really see your patients follow up. Because it's a training facility, so you do the surgery, it's very nice, looks beautiful, but you may not see that patient again because different service, you rotate.
Dr. Evans will see him.
So
That's exactly what happens.
in the academic, the patients rotate, the residents we trade. So a lot of times you don't really see your outcomes. Now in private practice, guess what? Every patient we did the laparoscopic Nissen, I would see in follow-up. And I can tell you, the patients would come back. As far as heartburn goes, it's a very good procedure. I will make sure it is a very good option to treat heartburn. It works in the right hands. Now, if you're going to be getting a laparoscopic Nissen fundoplication, my advice to you, make sure you have it done by someone who does a lot of this.
And isn't the learning curve, it's about 50 cases, right?
50?
You have to do 50 Nissen fundoplications before you're really good at it.
And there are guys that are colleagues, and I meet them at the American College meetings, we talk about different procedures. Make sure you go to someone who's doing this on a routine basis. They actually specialize in it. You don't want to have this done by someone who does it once a year or even once a month. It really has to be somebody who does it once a week, because the anatomy is not easy, and the complications definitely been shown to be higher in it was done with somebody who doesn't do a lot of this, the experience level. So make sure you go to somebody experienced. Now, in the hands.
That's the old-fashioned one.
So laparoscopic Nissen done by experienced personnel, experienced surgeon, and I did a lot of those. The problem that I saw, the main problem, is what we call gas bloating. So patients basically had this gas pain, and it can be disabling. And the patient will say to me, "Doc, my heartburn is, thank you, I'm off heartburn medications, but I've got this constant gas sensation right here in the epigastric area." And the other problem that I saw in my own patients was dysphagia, which means difficulty swallowing. And that is a significant percentage of patients. Even in good hands, it does happen.
And you're good because you're following your patients.
I'm following all of them.
A whole lot of them, they end up coming to me and because the surgeon hasn't followed them, and then I've got to try to figure out how am I going to fix this problem.
And it's a difficult problem to fix.
I've got a horrible anecdote. I have a surgical friend who had a Nissen fundoplication.
Okay.
And yeah, a surgeon.
Wow.
A surgeon.
Wow, he had the
He had the fundoplication. This has been years ago, so I know TIF was not available in our area at that time. I'm not even sure they had it then. But he had such bad heartburn, he had to do something. He gets that done. His gas bloat was so bad, he had chest pain and abdominal pain in the operating room one time.
Oh, wow.
They thought he was having a heart attack. They had to pull him aside, and then he found out it was gas bloat. He carries a nasogastric tube with him. Wow. So if it happens again, this is unbelievable.
Wow.
But it was such a horrible experience.
Yeah.
He carries a nasogastric tube, so he can put the tube down into his...
To relieve the gas?
To relieve the gas if it happens again.
Only a surgeon will do that.
Yeah, do not...
Don't try this at home.
Try this at home.
Unless you're a surgeon and you can do whatever you want to.
And by the way, he's a great surgeon too. This guy was good. But so it can be bad. And the numbers I quote to patients are maybe as high as 12 to 24% of patients with a Nissen may have complications. Okay. Now, that's kind of all comers. And again, a really skilled surgeon who is doing these all the time won't have numbers anywhere near that. Right. I think there was a guy in the Netherlands, a surgeon, who said his complication rate was about 3%. And he was doing them all. That was what he did.
I feel if you go to someone like that, off the top of my head, I can't think of centers who they do Nissens with a large volume.
Go to Amsterdam.
So maybe go to Amsterdam with a 3% complication rate. Now, if you're out there, if you're listening on Facebook and you have this dysphagia from a Nissen, it's a tough problem. It's a really tough problem. And I'm sure if you're that patient, you know that you go from physician to physician. What they can do for you is dilate. But a lot of times you really have to go in there and undo the Nissen fundoplication, which is not fun for the patient or the doctor.
Right.
I have patients every few months, they have to come in, I put them to sleep, do the endoscopy, stretch open their throat, and for a few months they're okay, but it comes back because the surgeon did a good job tightening things up.
Right,
but,
right.
A little too good, I'm afraid.
Too tight.
And sometimes what I've seen with Nissen patients is initially they don't have dysphagia, so it's good. But over time, because of, a Nissen fundoplication, you actually change the anatomy of this area. So you don't, when you're done, it doesn't look like normal anatomy, which is different from a TIF procedure because when you're done, it looks like normal anatomy.
That's a good point.
Because of that, over time, scar tissue starts to form. And I've had my own patients, they go for 3 years, no problem, and they show up after 3 years and they say, doctor, now I'm having a hard time swallowing.
Funny you should mention that.
Yes, I'm sure he has a specific.
I have really mild dysphagia. If I sit down in front of a bowl of white rice and start just scooping it in really quickly, I'll feel food catch there for a moment, and then I just kind of have to wait it out. It's not a good feeling, and then it passes.
Yeah.
It isn't bad for me, and I have my voice back. Thank you.
There you
Thank
go.
you.
There you go.
Thank you.
Well, we're going to take a couple of questions from Facebook. So, Lynn, go ahead and.
I never covered PPI problems.
That's okay.
That may come up.
It might come up in questions. Go ahead with the
So the first question we have is from Santrisha, and she's saying, I have reflux very badly. Does it also affect her breathing?
Ooh, interesting question. Okay, I can give numbers there too. Adult onset asthma, 80% correlation with acid reflux.
Absolutely.
80%. It's huge. Sleep apnea, high percentage of association. I can't give you the numbers, but a high percent are associated with acid reflux.
So the answer is yes, clearly,
the answer
right?
is definitely
yes. Sleep apnea.
Yeah.
Yep. Okay.
And the second question is, will I need to be on any kind of special diet prior to having a TIF procedure?
My guess is you're on a diet trying to stop reflux already.
Right. So generally,
But you don't have to be on
when they
special.
come in, do you normally do you normally tell them to change their diet changes first, or is that ever a treatment option first?
That is
before PPI?
always a treatment option. Right. Always. The patients that are referred to me are way beyond it. That's already been discussed.
So, okay.
Because as a specialist and a surgeon, the patients, but a lot of times patients come directly. So if the discussion was not made before, if they didn't talk about that before, then absolutely lifestyle modification, which is, raising the head of the bed, smaller meals, obviously changing the diet, weight loss, all those things help.
Don't eat after 5 o'clock at night.
5 o'clock at night, don't eat at bedtime. So all those things are definitely discussed.
Right.
I want to mention about the diet.
Prior,
If I want to add something about the diet, it's a very important question because the TIF procedure, it is indicated, and one of the requirements is to have a BMI. The BMI is the basic metabolic index, that is 35 or below. So if you're listening and your BMI is more than 35, then to answer your question is, if you're 37, if you're 40, then yes, we're going to talk about a diet to motivate you and get you down to 35. And then once the workup is complete and you're a good candidate, you'll have the procedure. And then here's the good part. There is a diet that is mandatory that comes with this procedure. That everyone goes on this on this diet. Everyone, we counsel every patient in the office. We'll give them a sheet of all the things that they cannot have. And with that diet followed, which I have a very high compliance with that diet. I'm still trying to understand. Close to 99% of my patients will follow that diet.
Is it like forever?
Yeah, how long do you do the diet for?
The diet, I do it for 12 weeks. It's a 12-week diet after the procedure. and my average weight loss, again, this is not a weight loss procedure, but because you had the procedure, because you're following the diet, we have about 25 to 30 pounds weight loss.
Wow.
So if you're perfect scenario, you're 40 BMI, we're gonna work together on a diet of your choice to get you down to 35. We're gonna do the treatment, do the procedure. We're gonna lose another 35, 40 pounds. Now we're down about 30. So we've got 2 birds with 1 stone. We took care of heartburn and we've knocked off 10.
Do you find that a lot? Because often when I have a patient come in that is into the morbid obesity category, that's 40 BMI
Higher.
and higher. I'm talking gastric bypass surgery at that point.
Yeah, that too. I mean, it's 40 BMI and above. So our target, the patients we're talking to, I agree 100%, 40 and above.
Right.
Now we got that window because a lot of times to have bariatric surgery, your BMI needs to be about 40. I know they're trying to say 35. In my opinion, I think it should be 40 and above. I think bariatric surgery is a very invasive procedure. It's a very invasive, it changes all your anatomy. But again, go ahead and do that procedure if you've got that morbid obesity, which is 40,
Right.
at least 40 and above. So we're talking about the window of patients below 40. So above 40, I agree 100%. It would be a referral for that bariatric surgery first,
Sure.
which might actually improve the heartburn.
Yeah.
But there are some studies that say the heartburn actually gets worse after bariatric surgery. So now it gets a little bit
Now we're going
confusing.
down a whole
I have-
road.
It gets confusing, yes.
I have my own opinions there,
Yes.
and I'm not a bariatric surgeon, so I should just keep my mouth shut.
We've got some more questions about GERD. So let's. What do we got, Lynn?
How long is the recovery time after a TIF procedure?
I can do that one.
Yeah.
So
Okay.
so basically, to simplify, there's 2 types. There's a straight standard TIF procedure, which is if you have a small hiatal hernia, the recovery is a same day go home or the overnight stay in the hospital. I would no more than maybe 3 to 5 days off work. We can call it a week just to be on the safe side, but there are patients, a lot of my patients will return back to normal activity before 1 week's over. But up to 1 week we can say full recovery.
And that's my wife. She just had the straight TIF.
And she did great.
She did well.
But if you combine it with the hiatal hernia repair, then it's probably 1, maybe 2 days in the hospital.
And this is me.
Yes, and but he probably went to work very early.
A little too early.
Too early, but to be safe, up to 2 weeks of full recovery.
I went back in 10 days. I was able to work, but I wish I'd taken 2 weeks off.
I think 2 weeks is a good benchmark, but we have exceptions. We have folks that have gone back to work in 2 days.
Oh, wow.
There's a lot of examples, but for the majority of patients, about 2 weeks full recovery.
But and the reason for that is because you want to heal properly, right? You don't want to lift anything heavy as to...
There's a lifting restriction,
Right.
absolutely. Pain is not a big problem, but I think up to maybe 3 days can be some pain. It's not severe pain. And a lot of that pain is controlled by oral medications,
Right.
not IV medications.
Do you feel the same pain-wise?
I do.
Okay, manageable?
I mean, for me, it was just I was more tired than I like to be
Okay.
for a couple of weeks. And I really didn't want to go back to a full schedule. In retrospect, I should not have gone back to a full schedule at 10 days. I should have gone on a very mild schedule and then worked back up.
Okay. Well, thank you. Lynn, any other questions?
No, not right now. I'll keep them coming.
Fantastic.
PPIs.
Yes, let's talk
Okay.
briefly. I know you wanted to chat a little bit about PPI.
One of the things that I believe is wonderful about the TIF is it affords a good chance of the patient being off proton pump inhibitors or PPIs. Omeprazole, pantoprazole, there's a number of them. And there's a growing body of literature that ties adverse events
Sure.
to the proton pump inhibitor. They aren't certain that that's what's causing it, that the proton pump inhibitor is the bad guy. but this correlation, and it keeps growing all the time. What correlations? Well, risk of lung infection, that definitely goes up. Recently, they've reported that the microbiota, your own bacteria, gets altered by PPIs. We don't know exactly what that's going to do, but it's changed. There is an association with hip fracture, wrist fracture. Well, the question is that because of osteoporosis? Okay. Not quite answered yet. Gotcha. But there's this association. And then there's, these are the ones that are really frightening. Kidney disease. We know that some people get severe kidney disease with PPIs. Not many. It's small, but it happens. There's an association with heart attacks and an association with Alzheimer's disease. I mean, is the PPI causing that? Well, some of those things we're sure of, a lot of them we're not, but I'll tell you, I wasn't going to stay on PPIs the rest of my life. I wasn't going to do it.
Well, there you go. So, said from a GI.
Yeah, I saw Dr. Salem. I wanted to get off of proton pump inhibitors, and I did.
There you go.
Not everyone does, but most people do.
So no more PPIs for you at all?
I may take one on rare occasions. Okay. So I can't even remember when the last time was I took one.
Keep in mind, reflux does happen to normal people that don't have, per se, a GERD, right? It's called physiologic. So, when you're under stress, if you have a very spicy meal, you can have a occasional heartburn. That's okay.
Right.
We're talking about folks who are sort of, they come in and they tell me, doctor, I'm drowning in acid. Right. They are literally drowning in acid. It is a daily, nightly, evening, everything. These are the patients we want to help. Right. But for the folks out there, these are the folks that started taking it because their neighbor, because their friend are taking it. And they start taking it because they got one episode of heartburn and they've just decided they're going to commit themselves to PPIs for life. Don't be that patient. The patients we want to help are the ones who are having daily heartburn, or it could be every other day, the significant heartburn. But once in a while, like Dr. Evans, he says, once in a great while. I mean, he's in a high-stress job, and so once in a while, he's got some heartburn, and so he takes some medication. That's okay. That's physiologic. It's normal.
Well,
seems like there was something.
Oh, we have one more question.
Okay.
Sorry.
Oh, it's okay. Do you want to proceed?
Go ahead. I'll have to think of what my comment was. Oh, I know. Evaluation with a Bravo or a pH monitor. We haven't really covered that. And that, actually about 50% of patients on proton pump inhibitors don't have significant acid reflux. Yep. They're just on these PPIs, which may have complications. And if you test them, they don't have it.
Yes.
Right. Tell me more about that.
I will say probably once every 2 months, I'm proud to say that I will take someone off PPIs. And that's what I did. I mean, they come in to see me as a specialist in heartburn, and I do a very simple acid test, which is they call the Bravo, measuring the acid that refluxes into the esophagus. And I come back and say, guess what? It's normal. Stop taking these medications. And they think I'm brilliant. And
that's interesting.
And the test is very easy. All I've done is just proven that they're on the wrong medication. Wow. So I take them off it, and we're friends and we're done. And I have those patients done.
And I will tell you that when I brought my wife in to see you and wanted her to get repaired, I said, I've been feeling a little bit, maybe I've got heartburn again. And you did the pH test or the acid test on me again.
I forgot that. Yes.
Yeah. And this is over 4.5 years out.
Almost zero.
Almost zero. It was some mental thing, probably because my wife was having heartburn. I figured I must be having it too.
Symptoms.
The stress. Actually, that's a very good point. Is having done what's called a baseline acid test is very important. Number one, for diagnosing GERD and confirming GERD. Number two, if you're going to get a procedure done, most of you are young. Middle age, this is not a deadly problem. This is not like cancer. So you'll be around for many years, right? So you'll have the procedure. Then 10 years later, or 5 years later, like Dr. Evans, you say, I think I've got heartburn again. Well, guess what? We check the acid again. Right. But because we have a baseline, we can now compare and say this is the acid before
Very good point.
and this is the acid after. The fact is, well, maybe it came back a little bit, or maybe you actually don't have acid reflux. So it's nice to have that.
And it was nice to know I was just having a reaction to my wife being so ill. I didn't have any acid reflux.
It wasn't acid reflux.
One more thing about PPIs to know is and that's probably the more common thing that I see, is the drug-drug interaction. A lot of patients have heartburn, have other medical problems. There's a whole list of drugs that you cannot take with all the PPIs.
They require acid to be processed by the body appropriately, and you shut off the acid, and then there's also ones that chemicals actually interact.
If you go fill certain prescriptions, I know for sure Plavix, for those of you who've got cardiac problems, you're on Plavix for a stent, and you go try to fill that prescription for a PPI, now hopefully you don't get it yourself. So a warning, if you're on Plavix, you cannot have that.
And that's debated in the medical literature too, and it doesn't look like it's every PPI, but you need to be seeing your doctor, your cardiologist, and discussing it with him or her before you start taking an over-the-counter medicine.
Yeah. So I just like to say I'm very excited to be doing this procedure. I'm glad I'm doing this procedure. It's excellent for my patients.
And I'm thrilled too. I've had wonderful results with my patients that I've done TIFs on, and it just opens up this whole new way of treating patients with a very low side effect profile, about 1% chance of side effect, versus this huge, much larger side effect profile with the traditional fundoplication. So I thank you as a patient. I thank you as a doctor.
I love it. I love it. Did we have another question?
We had one last question. I think it's perfect timing. This is more for you, Andrea. Okay. But if I don't live near Dr. Salem or Dr. Evans, where can I find a TIF doctor in my area?
That's a very good question, and thank you for asking that question. Before, so to answer that question, if you're looking for a doctor that does the TIF procedure, you can go to gerdhelp.com, so that's www.gerdhelp.com, and there's a list of physicians in your area. You just put your zip code in or your state, and you'll be able to find the nearest physician in your area. But before we end today, I do want to thank Dr. Evans and Dr. Salem for being here. This has been a unique situation for us and very exciting for me, and I hope for you guys too, to hear a story. You heard it yourself, a GI that does the TIF procedure, has a TIF procedure, recommends it, and Dr. Salem as well, who does the TIF procedure here. And we're in Orange County, California, so if you're in the area, you can come and see one of these fine physicians. But again, thank you for being here and talking with us today. We really appreciate your time, and we appreciate everything you guys do.
Thank you so much.
Anything else to add?
Well, thank you so much for having us, and as Dr. Evans is my patient, maybe one day I will be his patient.
Oh, there you go. Full circle.
So I know who to go to if I have heartburn now. It'll be Dr. Evans.
Thank you very much for joining us tonight, and we will catch you next time. Thank you.